Bismillahirrahmanirrahim. Assalamu alaikum. Today, inshallah, we will cover a new topic which is the muscles of the anterior compartment of arm. First of all, what is arm? The arm, which is also called as the brachium. See here in this diagram, the arm is called as the brachium. It is the proximal segment of the upper limb from shoulder to the elbow. This is called as arm. The distal region is called as forearm. But today we will see that which muscles are present in the anterior compartment of arm. First of all, the osteofacial compartments. The arm is enclosed in a sheath of deep fascia. Two facial intermuscular septa. See here in this diagram, there are two intermuscular septa, one on the medial side, which is called as medial intermuscular septum, and one on the lateral side, which is called as lateral intermuscular septum. They are present. They are extending inward from this sheath, that is the sheath of the deep fascia, and they are attached to the medial and the lateral supracondylar ridges of the humerus respectively. That is, the medial intermuscular septum is coming from the deep fascia and it attaches to the medial supracondylar ridge of the humerus. And the lateral intermuscular septum, it is coming from the deep fascia going downwards and it is attached to the lateral supracondylar ridge of the humerus. In this way, the upper arm, the upper arm is divided into anterior compartment and the posterior compartment. Each compartment will be having a set of muscles, nerves and arteries. That is, there are some muscles which are present in the anterior compartment which are supplied by a specific nerve and artery, and the posterior compartment will be having separate muscles which are again supplied by a different nerve and arteries. See here in this diagram, this is humerus bone, this is lateral intermuscular septum, and this is the medial intermuscular septum. This is deep fascia. You can see here, this is deep fascia. So medial and the lateral intermuscular septum, they are coming out from the deep fascia and they are attached to the medial supracondylar ridge and the lateral supracondylar ridge of the humerus, and they will divide the whole of the upper arm or the brachium into anterior compartment. This is anterior compartment and this is the posterior compartment, each having its own nerve. See here, this is the nerve of the posterior compartment and this is the nerve of the anterior compartment of the arm. Again they will have their separate arteries. In this diagram you can see this is the arm or the upper arm or the brachium, and this is the anterior compartment of the arm. It is having its own muscles, own arteries and own nerves. See here in this diagram, they have shown the anterior compartment here. This is the muscle brachialis. This is the biceps muscle which they have removed, and this is the Coracobrachialis muscle. In this diagram also they have shown the brachialis muscle. This is the posterior compartment of the arm, but today we will discuss the anterior compartment. First of all, we will see that which muscles are present in the anterior compartment. They are biceps brachii, coracobrachialis and the brachialis muscle. See here again, three muscles are present in the anterior compartment. Number one is biceps brachii, number two is coracobrachialis, and number three is brachialis. And the nerve is the musculocutaneous nerve which is supplying all these three muscles. And the brachial artery is present here in the anterior compartment and it will supply all these three muscles. Now, what are the structures which are passing through the anterior osteofacial compartment? The musculocutaneous nerve, which is the nerve of the anterior compartment of the arm, the median nerve, the ulnar nerve, the brachial artery and the basilic vein, they pass through the anterior compartment, and the radial nerve is present in the lower part of the anterior compartment. I will tell you what structures are present in the posterior compartment, but for the detailed posterior compartment you can see another video. This is the muscle which is present in the posterior compartment, which is triceps brachii. This is the only muscle which is present in the posterior compartment of the arm. The radial nerve is the nerve of the posterior compartment of the arm, and the profunda brachii artery, which is the deep branch of the brachial artery, and the ulnar collateral arteries, these are the blood supply of the posterior compartment of the arm. Now, the structures which are passing through the posterior osseofacial compartment are the radial nerve, the ulnar nerve, and the profunda brachii vessels which pass through these regions. See here in this diagram, they have shown all muscles, their origin and insertion. See here, this is the biceps brachii and the coracobrachialis muscle, which are originated from the coronoid process of the scapula. This is the coronoid process of the scapula. The coracobrachialis will be inserted on the middle part of the humerus bone. Okay, here you can see the whole biceps brachii muscle. Okay, first of all, this is the short head of the biceps brachii, and this one is the long head of the biceps brachii. In this one, they have shown the coracobrachialis muscle as a whole. This is the coracobrachialis muscle. Then the brachialis. So there are three muscles. Number one is biceps, number two is coracobrachialis, and number three is brachialis muscle. Okay. This is the posterior compartment. They have shown here the triceps. Okay, this is the triceps which is present in the posterior compartment of the arm. Now the origin, insertion, the innervation and the muscular action of the muscles of the anterior compartment of the arm. First of all, the biceps brachii. Biceps brachii is originated from the two heads. It is having two heads. One is short head and one is long head. The short head originates from the tip of the coracoid process of the scapula. See here, I have told earlier that it is originating from the coracoid process. This is the coracoid process of the scapula, from where the short head of the biceps and the coracobrachialis, they are originating. Okay, the long head originates from the supraglenoid tubercle of the scapula. It is originating from the supraglenoid tubercle. See here in this diagram, this is the supraglenoid tubercle of the scapula, from where the long head, this is the long head, and it is passing through the transverse humeral ligament, and it is originating from the supraglenoid tubercle of the scapula. So this is the long head of the biceps brachii. This biceps brachii, it is inserted over the tuberosity of the radius. In the radius, there is bicipital tuberosity. Why it is called as bicipital tuberosity? Because on the radius the biceps is inserted. So you can see here in this diagram that biceps, it is inserted over the bicipital tuberosity or the radial tuberosity on the radius. Okay, so this is the bicipital tuberosity. Innervation is the musculocutaneous nerve, which is having the root value C5, C6 and C7. What is the function of the biceps? It supinates the forearm, supination of the forearm, because it is crossing the elbow joint, so it will act over the forearm also, and when it is supine, then it will flex the forearm. Okay, short head resists the dislocation of the shoulder. First of all, it is supinating the forearm. Okay, but when it is supine, it will flex the forearm, and the short head resists the dislocation of the shoulder. Number two muscle is the coracobrachialis muscle. It is again originated from the tip of the coracoid process of the scapula. See here in this diagram, it is originated from the coracoid process of the scapula, along with the short head of the biceps, and it is inserted over the middle third of the medial surface of the humerus. It is inserted over the medial surface of the humerus, not over the lateral surface. You have to remember this thing, that it is inserted over the medial surface. This is the middle part of the medial surface of the humerus where it is inserted. Again, the innervation is same, the musculocutaneous nerve with the root value of C5, C6 and C7, and it helps the flexion and the adduction of the arm. It resists the dislocation of the shoulder. So it is helping in the flexion of the arm and the adduction of the arm, because it is inserted over the medial side, so it will adduct the arm. Number three muscle is the brachialis muscle. Brachialis muscle is originated from the distal half of the anterior surface of the humerus. See here in this diagram, you can see that brachialis is inserted from the distal half of the anterior surface of the humerus. Okay, and it is inserted over the coronoid process and the tuberosity of the ulna. Okay, coronoid process and the tuberosity of the ulna. Okay, it is inserted over the ulna. Again, the nerve supply is same, the musculocutaneous nerve and the radial nerve. Okay, C5, C6 musculocutaneous nerve, and the radial nerve C5 and C6, C7. It also flexes the forearm in all positions. Okay, it will flex the forearm in all positions. So what we have discussed about brachialis, it is originated from the distal half of the anterior surface of the humerus, and it is inserted over the coronoid process and the tuberosity of the ulna. For ulna, the process is coronoid process. For scapula, it is coracoid process. Okay, so you can see here it is inserted over the coronoid process and the tuberosity of the ulna, and it is innervated by the musculocutaneous nerve. Okay, it flexes the forearm in all position. Now we will discuss the muscles again. The anterior compartment of the arm is divided by the humerus the medial and the lateral intermuscular septum into the anterior and the posterior compartments. The muscles were the biceps brachii. This is biceps brachii. There is coracobrachialis, and you can see the brachialis here. When we will remove the biceps brachii, then we can see the brachialis muscle very carefully. The blood supply is brachial artery and its veiny comitants. The basilic vein is present in the upper half of the arm. The nerves are the median nerve is present in the lower part of the arm, in the middle part. The ulnar nerve is present in the upper half of the arm, and the musculocutaneous nerve is the main nerve which is present, and it is supplying the muscles of the anterior compartment of the arm. Again, they have discussed separately. See here, coracobrachialis from the tip of the coracoid process. See here, this is the coracoid process of the scapula along with the short head of the biceps, and it is inserted on the middle part of the medial surface of the humerus. It is supplied by the musculocutaneous nerve, and there are two actions of the coracobrachialis. One is flexion and one is adduction of the arm. Every muscle, when it is inserted over the medial side, it will adduct the arm. But if it is inserted over the lateral side, then it will abduct the arm. Remember this thing. This is biceps brachii, the short head from the coracoid process of the scapula, along with the coracobrachialis, and the long head from the supraglenoid tubercle and passing through the transverse humeral ligament, and it is present here. Then it is inserted over the posterior rough part of the radial tuberosity. See here, this is the radius bone on the lateral side, and on the medial part of the bone, there is the radial tuberosity, where the biceps muscle is attached. Okay, the medial side of the tendon form the bicipital aponeurosis, which blend with the deep fascia. This is the medial part of the biceps muscle, and it is forming the bicipital aponeurosis. This muscle is also supplied by the musculocutaneous nerve. And what are the actions? Number one is the flexion of the elbow joint. It will flex the elbow joint. It is the powerful supinator of the flexed forearm. That is, if the forearm is already flexed, so it will supinate the forearm. The short head helps in the flexion of the arm. The long head keeps the head of the humerus in contact with the glenoid cavity during the movement of the shoulder. Although the biceps is located in the anterior compartment of the arm, it has no attachment on the humerus. You have seen here that it is originated from the scapula and inserted over the radius. So it is not attached to the humerus bone. Okay, the bicep is a three-joint muscle, crossing and capable of affecting movement at the shoulder joint, at the elbow joint, and the radio-ulnar joint. Although it primarily acts on the elbow joint and the radio-ulnar joint. Remember this thing. It is not attached on the humerus. It is a three-joint muscle. That is, it is crossing the shoulder joint, it is crossing the elbow joint and the radio-ulnar joint, which is the proximal one. So it will act on these three joints. Its actions and effectiveness are markedly affected by the position of the elbow and the forearm. When the elbow is extended, the bicep is a simple flexor of the forearm. However, as the elbow flexion approaches 90 degrees and more power is needed against the resistance, the biceps is capable of two powerful movements depending on the position of the forearm. Okay, remember this thing, that when the elbow is extended, the bicep is a simple flexor. Okay, and when it reaches the 90% flexion and more power is needed against the resistance, the bicep is capable of two powerful movements depending on the position of the forearm. When the elbow is flexed, which is close to the 90 degrees, and forearm is supinated, the bicep is most efficient in producing the flexion. Remember this thing, what I have told, that when the elbow is flexed and close to the 90 degrees, for example in this diagram, and forearm is supinated, then the bicep is most efficient in producing the flexion. Alternately, when the forearm is pronated, if it is pronated, and bicep is the primarily supinator of the forearm. For example, it is used when right-handed people drive a screw into a hard wood, and when inserting a corkscrew and pulling the cork from a wine bottle. The biceps barely operate as a flexor when the forearm is pronated, even against the resistance. In the semi-prone position, it is active only against the resistance. Now the brachialis muscle, this is present in the lower part of the arm, lower part of the anterior compartment or the front of the humerus. It takes origin from the medial and the lateral intermuscular septum, and it is inserted in front of the coronoid process of the ulna and the tuberosity of the ulna. Okay, it is supplied by two nerves, medial part from the musculocutaneous nerve and the lateral part from the radial nerve. It is the main flexor of the elbow joint. See here, it is the main flexor of the elbow joint. The brachialis muscle is the main flexor of the forearm. Sometimes in viva it is asked that which one is the main flexor of the forearm. So it is the brachialis muscle. It is the only pure flexor producing the greatest amount of the flexion force. It flexes the forearm in all positions, not being affected by pronation and supination. During both slow and quick movements and in the presence or absence of resistance. That is, it flexes the forearm in all positions, whether it is in pronated position or supinated, whether they are doing the slow movement or the quick movement, whether the resistance is present or absent. When the forearm is extended slowly, the brachialis steadies the movement by slowly relaxing, that is eccentric contraction. The brachialis always contract when the elbow is flexed and primarily responsible for sustaining the flexed position. Because of its important and almost constant role, it is regarded as the workhorse of the elbow flexors. It is also called as workhorse of the elbow flexors. Remember this thing. These questions can come in your MCQ. Workhorse of the elbow flexor is which muscle? It is the brachialis muscle. Now some of the clinical applications. Bicipital myotatic reflex. The biceps reflex is one of the several deep tendon reflexes that are routinely tested during the physical examination. The relaxed limb is passively pronated and partially extended at the elbow. The examiner thumb is firmly placed on the biceps tendon. See here in this diagram that the thumb is placed on the biceps tendon. Here there is the bicep tendon and here the thumb is placed. Then the examiner thumb is firmly placed on the biceps tendon. Then a normal positive response is an involuntary contraction of the biceps muscle felt as a momentarily tensed tendon, usually with a brief jerk-like flexion of the elbow. Okay, when the hammer is briskly tapped at the base of the nail bed of the examiner thumb, what will happen? A positive response will be involuntary contraction of the biceps. A positive response confirms the integrity of the musculocutaneous nerve which is supplying the biceps muscle. Okay, and this, what is the root value? The C5 and the C6. Excessive or diminished or prolonged response may indicate the central or the peripheral nervous system disease or the metabolic disorder, that is the thyroid disease. See here in this diagram, the thumb is placed over the bicipital aponeurosis and the examiner. Then what will happen? The contraction of the biceps muscle will be there, which will show that the musculocutaneous nerve is intact because it is supplying the biceps muscle. Then there can be biceps tendinitis. Itis means inflammation. So there can be inflammation of the tendon of the biceps muscle. The tendon of the long head of the biceps is enclosed by a synovial sheath and moves back and forth in the intertubercular sulcus, which is the bicipital groove of the humerus. In the humerus, there is a bicipital groove which is present here. Okay, so from where the long head of the biceps is crossing. Wear and tear of the mechanism can cause the shoulder pain. Inflammation of the tendon, which is called as biceps tendinitis, usually the result of repetitive microtrauma, is common in sports involving the throwing and use of the racket, such as in tennis. A tight, narrow or rough intertubercular sulcus may irritate and inflame the tendon and producing tenderness and crepitus, which is the crackling sound. See here, this is the bicipital groove or the intertubercular sulcus, which is present in the humerus, okay, which is in between the lesser tubercle and the greater tubercle of the humerus. That's why it is called as intertubercular sulcus. From this intertubercular sulcus, which is also called as bicipital groove, because biceps muscle or the long head of the biceps is crossing through this bicipital groove, okay, and here it can be inflamed by many movements which are common in sports. It can be in baseball, in cricket, in tennis, and then there will be tenderness and there will be a crackling sound in the biceps tendinitis. Then there can be dislocation of the tendon of the long head of the biceps. See here, this is the bicipital groove or the intertubercular sulcus. The tendon of the long head of the biceps can be partially or completely dislocated from this bicipital groove of the humerus. This painful condition may occur in young persons during traumatic separation of the proximal epiphysis of the humerus. The injury also occur in the older persons with a history of the biceps tendinitis. Usually a sensation of popping or catching is felt during arm rotation. Okay, so here the tendon of the long head of the bicep is dislocated, maybe partially or completely. Then there can be rupture of the tendon of the long head of the biceps. The rupture of the tendon usually results from a wear and tear of an inflamed tendon as it moves back and forth in the intertubercular sulcus of the humerus. This injury usually occurs in the individuals which are more than 35 years of age. Typically, the tendon is torn from its attachment of the, where it is attached, the long head of the biceps. It is attached from the supraglenoid tubercle of the humerus. The detached muscle will form a ball. See here, it will form a ball near the center of the distal part of the anterior aspect of the arm, and this is called as Popoy's deformity. This is called as Popoy's deformity. Rupture of the biceps tendon may result from the forceful flexion of the arm against excessive resistance as occur in the weightlifters. However, the tendon ruptures more often as a result of the prolonged tendinitis that weaken it. The rupture results from the repetitive overhead motions such as occur in the swimmers and the baseball pitchers that tear the weakened tendon in the intertubercular sulcus. So the muscle will be ruptured and it will be forming a ball which is called as Popoy's deformity. See here, this is Popoy's deformity. This is distally displaced value of the long head of the biceps or the rupture of the biceps tendon. Thank you very much.